Welcome to Physics and Knobology. I'm Kat Ogle, an assistant professor of emergency medicine at the George Washington University. Today we're going to be talking about some key features of the physics in knobology, which ultimately will impact the way you image your patients. We're going to talk about some specific terminology you should be using, and we're going to talk about how to break it down in a systematic way. Ultimately, ultrasound is the transmission of sound waves through tissue for which your ultrasound machine generates an image. Interestingly, the ultrasound probe itself not only sends out the signal, but also listens for the echoes to return. This phenomenon, thanks to some brilliant physicists, is what allows you to see your patient's anatomy. In your traditional ultrasound probes, there's something called a piezoelectric crystal, which sits in the face of the transducer. These crystals are receptive to electricity, and once the electrical signal meets the crystal, they deform, generating a sound wave which goes through the transmission medium into your patient's body. Those sound waves will reflect or bounce off of the patient's tissue layers at varying speeds, given the intrinsic density. These reflected sound waves will return to the piezoelectric crystals, which again leads to a deformation, which is in turn interpreted by the machine as the varying shades of gray that you see on your display. Now, there are some newer ultrasound machine technologies which are derived from a micro machine sensor chip, which generates a variety of sound waves at different frequencies and results in the need for just one probe for all of the imaging modalities, and it connects to a phone or a tablet. Thankfully, you don't have to be a physicist to understand the interplay of physics and ultrasound. You do, however, need to know some physics, so let's go through these four key areas: frequency, attenuation, reflection, and amplitude. As you all likely recall, the frequency of a sound wave is most simply described as the number of cycles of a wavelength per second. This becomes important with ultrasound imaging because the frequency has an impact on the appearance of your images. Ultimately, higher frequency probes, or settings, are reserved for superficial structures as they provide incredible detail and demarcation between different tissue layers and structures. As such, high-frequency probes are typically reserved for procedural ultrasound, vascular, MSK, and soft tissue applications. That said, given the incredible detail, they can also be used to take a closer look at things like the peritoneum, appendix, and early pregnancy, as well as some lung ultrasound. Lower frequency probes or settings are typically used for those which are deeper in the thoracic or abdominal cavities. With these, you will note that they may sacrifice some level of detail, and you will often see these being used for echocardiogram, most abdominal imaging. With that in mind, however, there may be occasions in which a high-frequency probe provides insufficient depth to see the structure of interest. In those cases, the lower frequency probe may be used for shoulder, hip, and DVT ultrasound. These are very rough schematics of ultrasound probes or transducers which you may use. The upper left is the phased array transducer. It has a square face, which is in contact with the patient's skin directly, and it is a low-frequency probe. You may use it for most thoracic and abdominal imaging. The upper right is the endocavitary transducer, which may be used in any cavity, that is oral, vaginal, or rectal. It is a high-frequency transducer which provides significant detail for imaging, and it may be used to identify things like a peritonsillar abscess, obstetric and gynecologic pathology, or prostate pathology. It also has been used to guide procedures. The bottom left is the linear transducer, which is used for many superficial structures and procedures. As mentioned previously, depending upon the depth of the structure, you may need it for abdominal imaging as well. Finally, the bottom right is the curvilinear transducer. It has the largest surface area of any of the transducers you will use, and it is primarily for abdominal structures, however, can also be used for thoracic imaging. Attenuation describes what happens to sound waves as they enter the patient's body and interact with different structures of different densities. This is an important concept to understand because there will be some modifications you can adjust on the machine to accommodate for attenuation, particularly if it is hindering your visualization of key anatomy. Sound waves in general will move more quickly through fluid-filled structures, or what we refer to as fluid-rich structures. When we discuss these organs, specifically the ones that make good acoustic windows, these are the liver, the spleen, and the gallbladder. Sound waves will slow down significantly or get refracted at odd angles when they come into contact with air. This is why many times we say that air is the enemy of ultrasound. We will further discuss the implications of air in lung and soft tissue ultrasound later. Finally, highly dense structures such as bone or calcified stones, metal, or glass will reflect most of the ultrasound waves back at the transducer. In this case, anything behind that structure will be difficult to visualize and may result in either a shadow or a reverberation artifact in the case of air. As we discuss attenuation, it is important to recognize that when you adjust the depth of the ultrasound machine, you are simply adjusting the distance into the patient's body that the machine listens for sound waves to return. You are not adjusting the frequency of the sound wave. If you increase the depth, the machine is simply listening for a longer time period. And if you make it more shallow, it is simply listening for a shorter time period. Depth comes into play when we discuss attenuation because the farther the sound waves get from the transducer and the deeper they are in the tissue, the more the energy in those sound waves dissipates and ends up being either absorbed or refracted in different directions. This results in fewer sound waves coming back to your transducer and a subsequent degradation of the image in the far field. This is why deeper structures on ultrasound images are typically darker or more grainy. This also means the detail of these structures is diminished. If you look at your ultrasound screen on the right-hand side, you'll notice some hash marks which act like a ruler to help you see how deeply your sound waves are traveling into your patient. Acoustic impedance is an important concept to understand because it is dependent not only upon the density of the tissue you are ultrasounding, but also the frequency of the sound wave itself. You can think of impedance as the resistance of the tissue to movement of the sound waves. Because it is dependent not only on the density of the tissue, but also the frequency of the sound wave, sometimes making an adjustment to the frequency of the transducer can accommodate for varying densities of tissue. This is one reason why the ultrasound machine not only has different transducers with frequency ranges, but it also has specific settings for different examinations. A really smart physicist studied the average impedances of different tissue types and anatomic locations and made adjustments to each setting to optimize visualization of that tissue. This is why you should use the cardiac setting for echocardiography and the abdominal setting for abdominal images. Once you have more experience, you can manually adjust the frequency for your imaging, but for now, just use the presets in the machine. As mentioned previously, each ultrasound probe or transducer has its own intrinsic frequency, and each one has a range which is predetermined by the manufacturer. In general, the lower the frequency, the more deeply the sound wave will travel into the patient's body. At the same time, you will sacrifice some detail in the image due to absorption, reflection, refraction, as mentioned previously. In general, the higher the frequency of your transducer, the waves will not be able to travel as deeply into the tissue, but you will have tremendous detail, and you may be limited by the depth of that transducer. Now, the image on the left is an example of what will happen when the liver is being imaged without optimizing for impedance. The image on the right is an example of what happens to the image when you adjust what is called time gain compensation. You can preferentially adjust the gain at different levels of depth to accommodate for some of the challenges of acoustic impedance. In this case, on the adjusted image, the sonographer increased the far gain deeper in the image to account for some of the lost signal, which makes it easier to see some of the details in the deeper portion of the image. The third part of physics we need to briefly discuss is how reflective different tissues are. In general, the more dense a substance is, the more reflective it will be. The more reflective something is, the brighter or more hyperechoic it will be. The closer something is to being a liquid without any precipitants within it, like sludge in the gallbladder or a clot in a vein, the less reflective it will be, and it will in turn transmit the sound waves very well. This will result in an image which is more anechoic. One exception to the density concept is air, as air tends to be very reflective. Air will reflect most of the sound waves back to the machine, but it will also refract the sound waves in multiple different directions. This is why bowel gas or lung may sometimes get in the way when you're imaging different structures. The image on the upper left is demonstrative of what we call mirror image artifact. Mirror image artifact is what happens when there is a highly reflective surface behind a structure that you are imaging. An example is the diaphragm, and you will see this when you do your hands-on demonstration with the FAST exam in particular. The middle image demonstrates different types of reflections that you may see when you're using the linear probe. As mentioned previously, the denser a tissue is, the brighter it is, or more hyperechoic it is. For example, there is a hyperechoic squiggly line traversing in the soft tissue. There is also a hypoechoic squiggly line in the tissue. These represent what different fascia or other soft tissue planes may look like, such as adipose or muscle. The small black circles represent blood vessels, which may have a hyperechoic wall, particularly in the case of arteries. The upside-down hyperechoic U in the center of the image is similar to what you would see with bone, or the cortex of the bone, and it has a subsequent anechoic shadow behind it. And this is due to the highly reflective surface of the bone. The bottom right image is what you might see in an endocavitary probe with an early intrauterine pregnancy with a yolk sac and a fetal pole inside the uterus. In this left upper quadrant view of the FAST examination, you can clearly see multiple different echogenicities. The spleen to the right of the screen, also towards the patient's feet, is hypoechoic and homogeneous. You will also see the kidney coming into view at the bottom right of the screen. In the middle, you'll see a hyperechoic linear structure, which is the diaphragm. To the left of the screen, toward the patient's head, and also above the diaphragm, you can see multiple different echogenicities. There are some hyperechoic areas with reverberations behind them, and this is lung with likely some consolidations. And it's also picking up some of the sound waves and reflecting them back toward the transducer. At the very top of the screen, you can see an anechoic triangle, which indicates some fluid in the pleural space. The amplitude of your sound wave can be thought of as the part of the ultrasound wave which can generate heat. This is why we refer to it as the power of the signal. This concept is one from which we derive the principle of a LARA, as low as reasonably achievable, which means you should use the lowest amplitude setting which enables you to image the structure of interest. As mentioned previously, your ultrasound machine comes with specific presets for each image type. As such, so long as you are using the appropriate setting for the machine, you should also be following the principle of ALARA. This is most pertinent in pregnancy and ocular ultrasound. In general, we do not use color Doppler in pregnancy in POCUS due to increased power generated by the signal and the theoretical risk to the developing fetus. Ocular ultrasound is the other exam for which the power of the signal should be considered carefully. So let's talk about the key steps involved in actually obtaining your image. You must first choose your probe and making sure that you choose the proper probe or transducer for the structure of interest. For echocardiography, we use the phased array probe, which is a low-frequency transducer. You can tell it is a low-frequency image based on a couple of things. The shape of the image is similar to that of a baseball diamond, and you can also look at the depth markers on the right side of the machine to give you a sense for whether it is a deeper or more shallow structure. And in general, we perform echocardiography using low-frequency probes. This is the right upper quadrant view of the FAST exam. Again, you see the baseball diamond-shaped window, and the depth is approximately 18 centimeters. Most abdominal imaging will be performed using a low-frequency probe. This is a high-frequency probe using the linear probe. It is an image which is taken in M mode, which we will discuss further in OB, lung, and echocardiography. You'll also notice that the image is rectangular. Additionally, you can see on the right side of the screen that the depth is only 3.7 centimeters. This is another image using the linear probe. You can see the rectangular window as well as multiple blood vessels and a nerve. You can also see that the depth is only 2 centimeters. There's a lot of detail in this image, which is why we use it for procedures. This is another example of a high-frequency transducer, which we discussed previously. And this is the endovaginal image of an early pregnancy with a fetal pole and a yolk sac. The next thing we're going to discuss is how to actually manipulate the probe. And there are a couple of things to keep in mind when you're ultrasounding. At this point, I encourage you to pick up your phone and hold it like you would hold an ultrasound probe. It is similar in weight, and some of the movements can be helpful if you're physically doing it while I talk you through each step. First of all, I encourage you to use what's called a tripod hold. Think of it as a kickstand on your bicycle or a scooter, and so you're going to hold the probe transducer as you would a large crayon or marker, and then you'd put your pinky finger down to stabilize your hand. This ensures your transducer does not slip and slide around with all the gel, and you have better control over the movements. Make sure that you move slowly and steadily, as many times the novice sonographer moves their transducer around too quickly, which can make it difficult to discern different types of anatomy. Make sure that you're watching the screen when you're ultrasounding. This is because you are performing an ultrasound-guided imaging procedure rather than an eyeball-guided imaging procedure. You have to use the technology that's at your fingertips. Finally, it's important to use plenty of gel to make sure that you transmit those wonderful sound waves into your patient. The next thing you need to do is orient yourself to the screen. For most imaging, when we do point-of-care ultrasound, the convention is for all transverse images, the probe marker should be to the patient's right. For longitudinal images, the probe marker will be oriented to the patient's head. Echocardiography has its own orientation, which will be discussed exclusively in the echocardiography lecture. If you're imaging the patient in a transverse plane, the probe marker will be toward the patient's right, and this is equivalent to the axial images that you see on CT or MRI. If you are imaging a patient in the longitudinal plane, the probe marker will be toward the patient's head. And if you're scanning them from front to back, this is equivalent to the sagittal plane for CT, MRI, or comprehensive ultrasound. If you are imaging a patient in a longitudinal plane, but you're scanning from their side, this is equivalent to a coronal plane on a CT, MRI, or comprehensive ultrasound. And you'll notice that I said comprehensive ultrasound and not formal ultrasound. None of us are wearing formal wear to the ER. In the subxiphoid view of the heart, the probe marker is oriented to the patient's right. When you look at this image, Sunny, our sono friend, provides you a schematic on what this may look like on your patient, if they were a stick figure. In the image itself, if you look at the way the heart is oriented, the apex of the heart is to the right of the screen, or to the patient's left. This should make sense if you expect that the patient's apex of their heart is in fact located on the left side of their body. More on this during your echo lecture. Now, this is the left upper quadrant view of the FAST exam. The probe marker is oriented to the patient's head, which means on the screen, the spleen is on the right side, toward the patient's feet. The kidney is even farther to the right because it's also farther down toward the patient's feet. The diaphragm is the linear hyperechoic structure in the center of the screen, and it moves left and right as the patient breathes in and out, or cephalocaudal. Finally, the lung is the farthest to the left of the screen because it is closest to the patient's head. Next, we're going to talk about the movements of the probe. When you are a novice sonographer, it is really important to move the probe slowly, particularly because subtle movements of the probe make a big difference in the direction of your ultrasound beam. It is also helpful to move in only one plane of movement at a time. We are going to discuss the cardinal movements of the transducer so that we're all speaking the same language. There are 4 main movements of the probe. And as we go through these, I encourage you to think about your hand as a credit card thin slice of ultrasound beams coming out of your probe. Your thumb will be considered the probe marker, and your fingers will be considered the plane of sound waves coming out of the machine. Everyone ready for your sono hand? Now that you're ready with your sono hand, I want you to think about a really warm day. If it were a really warm day, you would use a fan to cool yourself off, right? Well, consider your fingertips as if they were an actual paper fan. The movement of the transducer in this case will be parallel with your probe marker or your thumb. And this is a movement which will allow you to take your ultrasound beam from one side of a structure all the way through it to the other. If you were doing a FAST exam, for example, the probe marker would be oriented to the patient's head, and you would fan anteriorly and posteriorly to move through the entire 3-dimensional space. If you were doing the transverse view of the bladder, your probe marker would be to the patient's right, and you would fan cephalocaudal, or from head to foot, again, allowing you to visualize the entire three-dimensional space. Some folks will also call fanning tilting. Rocking the probe allows you to aim your ultrasound beam toward the probe marker or away from the probe marker. In this movement, your ultrasound beam moves in plane with your probe marker. The way you would operationalize this is if you were performing a right upper quadrant view of the FAST exam, and you could only see the liver and you could not see the diaphragm. Because you know the diaphragm is toward the patient's head, you could rock your ultrasound beam in the direction of the probe marker, or your thumb, and potentially see the diaphragm. Similarly, if you were looking at a female pelvis in the transverse plane, you could rock either to the left or the right to get a view of the patient's ovaries. Another movement which will be important is rotation of the probe. Now this is simply twisting the probe on its axis, and the purpose of this movement can be to change the alignment of the ultrasound beam such that it can get between the ribs. Alternatively, this may be used to capture a structure in either the longitudinal or the transverse view. The heart, the gallbladder, kidneys, uterus, and blood vessels are just some examples of structures which can be imaged in both transverse and longitudinal views. Sliding is probably the simplest movement of the probe, and you simply just move it up, down, side, side, all around the patient's body in basically any direction. The key here is that you want to make sure that the probe face remains flush with the patient's skin. The next thing we're going to talk about is optimizing your image once you have identified the key structures. Adjusting your depth is an important part of optimizing your image. This is because you want the structure of interest to take up 2/3 to 3/4 of your screen. Now on this picture, the red squares and arrows highlight the areas on 3 different ultrasound machines where you may adjust the depth. The other thing that you're going to want to do is to adjust the gain. Now, modifying the gain can be done in each of these highlighted areas. And you want to adjust the gain so that anything that is liquid on your screen will actually be anechoic or black. This image shows you an example of what we call the Goldilocks principle of gain. On the upper left-hand side, the gain is too low and the image is much too dark. On the upper right-hand image, the image is much too bright and is way overgained. The image in the middle, or image C, has the optimal gain, and this is specifically an image trying to see the median nerve. When this gain is adjusted just so, you can clearly see the nerve at the very center of the screen. The last couple of slides we're going to go through are going to talk about specific sonographic terminology, which will be important for you guys to integrate into your language. Now, an acoustic window can simply be described as an area for which you can see the appropriate images that you're trying to visualize. The upper left-hand image is a lung ultrasound, and the acoustic window is simply between 2 ribs. For the image on the right, there's a subxiphoid view of the heart, and the liver ends up being your acoustic window here. On the bottom left is the right upper quadrant view of the FAST exam, and your best acoustic window is actually the patient's pleural effusion, which is an anatomic area that is bathing the dense atelectatic lung. Now, interestingly, on all 3 of these images, we can find hyperechoic structures. On the upper left, you have the visceral parietal pleural interface of the lung ultrasound. On the right, you have the hyperechoic pericardium. And on the bottom image on the left, you have the hyperechoic diaphragm. Now, there are other parts of this image which are also hyperechoic, but these are just some examples. On the next image here, we see things that are hypoechoic or darker gray. On the upper left image, the arrow is pointing to the superficial soft tissue and musculature just above the lung. On the echocardiogram view, you're actually visualizing the liver. And on the bottom left image, you're also visualizing the liver. Now, there are also some things on ultrasound which will be anechoic or without echoes, also known as black. On the upper left-hand side, the shadow that exists behind the rib due to a lack of transmission of sound waves is actually the acoustic shadow behind the rib. For the echocardiogram, the arrow is indicating the fluid inside the heart, or just the blood. Now, the reason that I didn't point out the pleural effusion on the right upper quadrant view of the FAST exam is because it's actually a little bit smoky. So it's not truly anechoic. The last thing I want to talk about here is isoechoic structures. Now, isoechoic is used to describe things that are the same echogenicity. This means that when you look at the shade of gray, it's equivalent across the board. So for the echocardiogram, some of the myocardium is actually similar in echogenicity to the liver. So we would say those are isoechoic. And those are also similar to the liver that's seen on the right upper quadrant view of the FAST exam. The last piece I want to discuss here is shadowing, because shadowing can be found in multiple different ways. First, you see the shadow that's behind the rib, and then interestingly, in the right upper quadrant view of the FAST, you also see some shadowing behind the lung and behind the pleural effusion. Those shadows are actually generated by the vertebral bodies, so it is another bony structure, but it's now on the back of the patient as opposed to the front of the patient. In general, let's talk about all of the ways in which you can optimize your images. So your step one is going to be to choose the appropriate transducer based on the body part that you're ultrasounding. Next, you want to hold the ultrasound probe like a tripod. You want to move slowly and methodically. Make sure that you're watching your screen rather than watching your patient. Use plenty of gel. You want to slide and rotate into your appropriate acoustic window so you can see what you need to see. Adjust your depth and gain so that your image is beautiful, and then fan or rock to complete your exam and go through the entire structure in a three-dimensional fashion. So here's a summary of our learning objectives, and just email us with any questions.